Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Maren. It's good to be with you. We've had a fabulous day so far, and we're expecting to continue on. Some very exciting stuff here this afternoon for you to listen to. I'd like to recognize this session sponsor, Maximus. I'm going to turn the time over to them for a brief introduction.
Good afternoon. I'm honored to sponsor today's session, Health Databases and COVID-19, Adapting the Data, Responding to Trends. My name is Dr. Karen Holzer, and I direct Maximus's new Public Health Data Analytics Division. Maximus is a large provider of IT and digital transformation initiatives for the government. We help clients in the public health space and beyond make the data actionable and resolve their most complex technology challenges. In addition, we are the largest citizen services partner to the US government, serving over 60 million citizens each year through programs such as Medicaid, TANF, SNAP, and SSI, SSDI. We also provide benefit appeals and independent medical reviews at scale. In fact, our healthcare professionals complete more than 1 million benefit appeals and independent medical reviews each year. Over the past 18 plus months, we have supported federal, state, and local government partners in their response to the COVID pandemic. We operate the National COVID-19 Vaccine Hotline for CDC, CDC Info, and support more than 23 states and localities in the COVID-19 response, including contact tracing, vaccine hesitancy, data analytics, and care coordination. Data is foundational to our ability to help our clients respond efficiently to the pandemic. For instance, we help them identify COVID hotspots or priority areas for vaccination. Data has also allowed us to understand the pandemic's impact on the communities we serve and the corresponding unmet needs. And data has been instrumental in understanding which interventions are effective at improving our program's effectiveness. I am looking forward to hearing from our esteemed colleagues this afternoon about their learnings. If you haven't already done so, please check out our exhibit booth. And thank you for attending this afternoon session.
Great, thank you, Maximus, for sponsoring us. We have on stage with us today Chris Krawczyk from OSHPD, California, soon to be HCI. Chris, how are you doing this afternoon?
I'm doing well, Norm. How are you?
Fantastic. All right, well, let's get into it. I'm going to turn the stage over to you, and we'll see what comes up next.
Okay, thank you, Norm. And again, good afternoon, everyone. Welcome to our breakout session this afternoon entitled Health Databases and COVID-19, Adapting the Data, Responding to Trends. I, too, also want to recognize and extend my appreciation to our sponsor, Maximus, for this session, and want to welcome our presenters this afternoon. We're going to have 3 presentations, each of them focusing on a particular area and response and impact of the COVID-19 pandemic. Areas that have actually come up in some other discussions today and that I think are particularly interesting. The impact on mental health and substance use, behavioral health, use of telehealth services, and then impact on cancer screening trends of COVID-19, and then the recovery or return to normal in terms of cancer screening. So those will be our 3 presentations. We will do each video, take a moment to answer some questions that come in chat, and then move into the next presentation. So encourage everyone to use the chat box to submit some questions to us. Hopefully we'll have a very dynamic and engaging session. And Without further ado then, we'll begin our first presentation from Christine Loveridge and Brian Beaman from Massachusetts Center for Health Information and Analysis. Their presentation is a methodology to identify and analyze hospitalizations with behavioral health comorbidities, preliminary findings from the COVID-19 pandemic.
Hello, my name is Christine Loveridge. I'm a manager of research at the Massachusetts Center for Health Information and Analysis, or CHIA. With me is Brian Beaman, a senior research analyst at CHIA. Today, I will discuss how we developed our methodology for analyzing hospital inpatient admissions with comorbid behavioral health conditions and present preliminary data on how the pandemic impacted behavioral health trends across the Commonwealth. Here is the agenda for today's talk. I will start with some background on CHIA's work on identifying behavioral health conditions and comorbidities. CHIA's research on behavioral health conditions in the inpatient setting emerged from its work on monitoring readmissions. From analyses using CHIA's acute care hospital inpatient discharge databases, one of the themes that emerged from our research was that across a wide range of conditions for which patients came to the hospital, those patients who also had mental health conditions or substance use disorders, that is, comorbid behavioral health conditions, had much higher readmission rates than other patients. In 2016, we published the first of 3 statewide all-payer reports analyzing the prevalence and readmission rates by behavioral health comorbidities using a methodology developed by CHIA to classify types of behavioral health using primary and secondary ICD-9 diagnoses. We adapted our methodology for ICD-10, starting with our second report in 2019. In light of the pandemic, CHIA also began publishing a new reporting series providing analyses of patterns and trends from the Massachusetts Acute Hospital Case Mix database, including our inpatient database. We published the first annual report on inpatient stays in December 2020, and starting in March 2021, we added quarterly updates as interactive dashboards on our website, which included trends in utilization and length of stay for discharges with behavioral health diagnoses. Next, I'll describe the current approach we take for identifying and classifying behavioral health comorbidities. To classify comorbidities for hospitalized patients, CHIA employed a broad approach in developing a list of behavioral health-related diagnoses. We reviewed multiple source lists, including the clinical classification software refined for ICD-10-CM published by the Agency for Healthcare Research and Quality, or AHRQ, statistical briefs also published by AHRQ, and condition categories from the CMS HCC risk adjustment model. The final categorization scheme has 10 categories of mental health and 8 categories of substance use disorders. Inclusion/exclusion criteria were reviewed by expert clinicians. All available diagnoses from inpatient discharge records were used to classify patients into 4 mutually exclusive categories: comorbid mental health conditions only, comorbid substance use disorders only, both, or neither. Because we were only using inpatient data, we knew we would not be capturing all behavioral health patients, and underreporting is a concern. We added a look-back period of 12 months prior to each inpatient stay when calculating comorbidities to capture more of the patients with these conditions. Before I get into the findings, I also want to share some considerations for researchers who are interested in using hospital data to pursue their own behavioral health-related analyses. First, there are several choices about how to define behavioral health conditions, which will depend on your analytic question. Consistent with the analytic approach of AHRQ, we chose not to classify intellectual disability or development disorders or degenerative disorders such as dementia as mental health conditions. We also excluded tobacco from our analyses. You may want to consider whether you want to include these or report them separately. The same goes for cannabis, where legal status by patient age might affect the extent of underreporting, as might other factors. In ICD-10, there are also distinct series of codes for the use, abuse, dependence, withdrawal, poisonings by, and adverse effects of substances. Which of these are important will likely depend on the specific substance, patient age, and other factors. The codes for screening and testing, personal history of, and family history of behavioral health conditions tend to be sparsely populated, but you might want to include them depending on your research question. For example, we included personal history of behavioral health conditions in our comorbidity calculation because it is highly predictive of elevated readmission rates. If you're planning to use data in or around the transition from ICD-9 to ICD-10, that will present its own difficulties. There's generally less granularity in ICD-9 and sometimes very different approaches to classifying behavioral health conditions. We also noted in our data some fluctuations in volume around the transition point. These were most notable when you drill down to specific subtypes of behavioral health. Finally, some diagnosis codes may be counted under multiple categories. An example would be poisonings by opioids with intent to self-harm, which could be classified as self-harm related or as opioids related. ARC recommends not modeling these categories as mutually exclusive, but this may be incompatible with your methods. Next, I will share some preliminary findings and trends in behavioral health conditions from our acute care hospital inpatient data before and during the pandemic. Because the most recent versions of the readmissions programs needed to construct our comorbidity measure are not yet available from CMS for the entire data period, I am presenting preliminary findings for any primary or secondary diagnosis and only using the subset of codes in the clinical classification software refined. Based on our analysis of earlier data years, we believe the overall prevalence would be a few percentage points higher if we were using our full comorbidity measure, but the trends will still look very similar. So this chart shows the monthly counts of inpatient stays in all acute care hospitals in Massachusetts from October 2018 to March 2021. I've represented discharges with any primary or secondary behavioral health diagnoses in orange and other discharges in blue. Up to January 2020, about 37% of inpatient discharges had behavioral health diagnoses. In the first 3 months of the pandemic, overall hospital discharge volume dropped over 30% as care was postponed or shifted away from the inpatient setting to the extent possible. This partially rebounded as the first wave subsided, then began sliding downward again as the second wave picked up in the colder months. Discharges associated with behavioral health conditions, for the most part, tracked overall trends in inpatient volume, although the proportion of behavioral health conditions did rise slightly in the summer of 2020 between the two waves of the pandemic. You can see that a little on this slide. On the left, you see the percentage of discharges with any mental health condition, and then on the right, for any substance use disorder. Prior to the pandemic, mental health conditions were present on 32% of hospital discharge records and substance use disorders on 14% of them. You can see the slight rise in both the proportions of discharges with mental health conditions and with substance use disorders. Substance use had a more distinct peak with the highest proportion in June and July of 2020. We also examined statewide changes in the average length of stay. Prior to the pandemic, hospitalizations were on average 1.4 days longer when behavioral health conditions were present. The average length of stay temporarily increased during both COVID-19 waves, with a slightly greater increase among the behavioral health cohort. Finally, I wanted to drill down into the top categories of behavioral health conditions in this period. Here you see averages for the most recent 12 months of data available. Mood disorders, which include depressive and bipolar disorders, as well as anxiety disorders, were the most common mental health conditions among hospitalized patients, with roughly 1 in 5 patients diagnosed with each. Among substance use disorders, the most common diagnosis category was alcohol use disorder, present on nearly 9% of discharges. The opioids epidemic has also been a major concern in Massachusetts before and during the pandemic, with almost 5% of discharges associated with opioids use disorder. Now to wrap up with a quick summary. During the pandemic, the volume of discharges dropped substantially on admissions for patients both with and without behavioral health diagnoses, resulting in a slight uptick in length of stay in both cohorts. The proportion of discharges with behavioral health diagnoses at 37% before the pandemic rose slightly during the summer of 2020 between the two waves of the pandemic, particularly for substance use disorders. Behavioral health diagnoses were associated with longer length of stay. And the most common mental health conditions were anxiety and mood disorders. The most common substance use disorders were alcohol and opioids use disorders. There are many more findings available on the dashboards on our website, including findings by diagnosis category, patient age, and obstetric cohort. These dashboards are also updated quarterly, with the next update to be out next month. If you'd like to find out more about the process of making these dashboards, I also encourage you to check out our spotlight presentation on that topic, available on demand throughout the conference. If you do have any questions or feedback for us that you wish to follow up with us about, here's our contact information. And now we will have some time for some Q&A. Thank you so much.
All right. Thank you, Christine, for your presentation, and thank you, Christine and Brian, for joining us for a little bit of Q&A. Looks like we do have a question that's come into chat, which is, how long did it take to establish the geocoding rules and aggregation?
That's a really great question. So on the dashboards themselves, we're actually not reporting by geography. All of our analyses are statewide. However, in our static reports, we do break out by 8 regions that are established by the Health Policy Commission of Massachusetts, which is one of our sister agencies. And that information is done by the zip code of the patient's permanent residence. CHIA has been, so that much doesn't take very long, because that was just an administrative decision, and from there the data is readily available on our data sets. But CHIA has been working on geocoding its case mix data. That has been something that we've been doing in conjunction with some scientists and a team at the University of Massachusetts, and that has been several months in development to ensure the accuracy and reasonableness of that data. And we are going to be doing, I think, more detailed geographic analyses, not necessarily public reporting at very, very detailed granularities, but we will be doing a lot of internal analyses with that data, and we'll also be using it to sharpen our model-based approaches that will be published. So using those fine-grained geographies, you can create much more accurate models. For example, in healthcare equity at a regional level, you can have a much better and clearer understanding, even if those will be published as aggregated statistics that are the result of models. So it is certainly a process that has been underway for many months at the agency, but we're very much looking forward to working on that.
Thank you. Okay. And certainly understand the level of granularity that you can go, is particularly in geocoding and still ensuring privacy, confidentiality. Another question that came in is, do you know if there will be any changes to the behavioral diagnoses in ICD-10?
So the transition from ICD-9 to ICD-10, that would be, so ICD-10 came into effect October 1st, 2015, which is the start of federal fiscal year 2016. And so we did quite a bit of analysis on that to try to understand what those differences were in terms of behavioral health. I'm not going to remember all of the details off the top of my head, but there were significant changes around disorders usually diagnosed in childhood. There were a number of changes around conditions that could be arguably considered development related or mental development related, which we consider to be something to be excluded from our model, but that's an analytic choice. Generally speaking, ICD-10 has a lot more detail than ICD-9. Many of the codes that were general got subdivided into more detailed diagnoses. There's a lot more information about whether diagnoses were initial encounters versus subsequent encounters or sequelae, which are the late effects of an encounter or of a substance, that is. there are a lot. I think going through this is something that there are summaries out there of the sort of changes, but I think it's very important to remember that it is very much a paradigm shift every time the ICD coding system changes. And when ICD-11 eventually comes along, it'll be the same story. We do believe, however, that ICD-10 seems to be doing a much better job of capturing the detail of an appropriate level of detail in that analysis. It's important to remember that it's kind of a learning process for medical coders and providers generally. So what we see is that for the first few years of ICD-10, there's a pretty heavy use of those other or unspecified codes where it's not as specific as you'd like to be, and it's unclear. Those volumes seem to have gone down and in favor of volumes of more specific codes. I think as people get more used to using ICD-10, and so that's something that we've been noticing a little bit in our data. That's why I think it's helpful to be aggregating to a slightly higher level than specific codes, but we do see a little bit more stable volume when you aggregate to higher levels. So aggregate over all disorders associated with a specific substance or specific general category of mental health, and even better when you aggregate to the level of all mental health, all substance use, all behavioral health.
Okay, excellent. Thank you, Christine. We do have a couple other questions I know that have been entered in the chat, but we're going to go ahead and return to those at the end if time permits. We do want to make sure that we allow time for our other presenters to present their videos. So we're going to turn now to the presentation from Katie Oberg from Center for Improving Value in Healthcare, Civic. And her presentation is Telehealth Services Analysis under COVID-19.
Hi there, my name is Katie Oberg. I'm a healthcare data analyst here at the Center for Improving Value in Healthcare, or Civic, and I'm here today to present our work on telehealth services in Colorado. First, a tiny bit of background about us. We administer the Colorado APCD, so we receive medical, pharmacy, and dental claims from a wide array of payers, including Medicaid, Medicare fee-for-service, Medicare Advantage, and over 40 commercial payers. In total, this represents about 4.3 million unique lives, which in turn is about 75% of our insured residents. The overall purpose of this project was to understand how telehealth services were impacting our healthcare system pre, during, and post-COVID. And then also sort of the broader goal was to create information that would support allocation of resources in order to enhance access to telehealth. Getting into our specific questions we were trying to answer, we were interested in understanding the trends in telehealth use, what types of services are patients using most frequently, why are patients accessing telehealth, what are those diagnoses on those claims, what types of providers deliver the most services, and then how does this all vary by region, age, and gender. And then a quick overview of our definition of telehealth. We applied a very broad definition, which includes both telemedicine, which is your classic phone call with a doctor or a video call with a doctor. But we also included additional categories of telehealth, including asynchronous communication. This would be communicating with your doctor through a patient portal or something like that, as well as including remote monitoring and transitional care management. Notably, our definition does not include provider-to-provider communication or consults. Getting into the data, this is an overview at a very high level, a trend in telehealth utilization throughout 2020. As you can see, through March and April, there was a very dramatic increase in telehealth use, which peaked in April at 232 services per 1,000 members per month. which amounts to an almost 3,000% increase from February and January. From there, as you can see, it does taper off a bit and the trend gets a little bit more consistent throughout 2020. And I think time will tell as to whether or not this is our new status quo or if there are more dramatic changes in our future. But for the next few slides, I'd like to focus on behavioral health, mainly because this is the most common reason for accessing telehealth. This was true both in 2019 when mental health conditions accounted for over 1/3 of all telehealth services, and it's even more true in 2020 where it represents over half. We're also starting to see an uptake in behavioral health, telehealth even before the pandemic. In 2019, we saw a 58% increase from January to December. And as you can see here, when we look at the trend in behavioral health, telehealth specifically, the line looks pretty different from the sort of overall use. We do see the same dramatic increase, in March and April, but unlike that first graph that we were looking at, it doesn't really come back down or taper off. It sort of remains pretty consistent at that peak in April, if not getting, a little bit bigger. And we can see that this is even more true for commercially insured members. We see that spike in April, but usage just continues to increase throughout 2020. And to put a finer point on this, the most recent data we have available shows that utilization in January of 2021 was 54 services per 1,000 members, compared to that same time last year in January of 2020. That's a 2,600% increase. So this is something we're definitely going to continue to look at as we receive more data and can really sort of extend that trend line out further into the future. But as I mentioned at the top, we were interested in understanding who was accessing telehealth and not just why. So one key finding from this demographic analysis is that Medicaid enrollees have the highest utilization rate in 2020 out of all of the different payer types. And this population accounted for over half of all telehealth services in the state. And notably, tying back to the behavioral health side of things, almost 2/3 of telehealth visits within the Medicaid population were for mental health reasons. Another key takeaway from this was that urban counties tended to have higher utilization rate than rural areas. Urban counties also had a more significant, more dramatic increase in telehealth use in 2020, which leads me into sort of my last slide here. As the data that I've been presenting so far definitely demonstrates that there has been a significant increase in adoption of telehealth, but it's important to recognize that there are still some barriers to accessing this care. On the provider side, there historically have been differences in the reimbursement rates for providing care via telehealth versus in person. And sometimes technology can be a barrier and make things inefficient for providers. On the patient side, the biggest barrier can be a lack of broadband connectivity. This is especially true in rural areas, which ties back to what we're seeing in our own data. Colorado is definitely a pretty rural state. And so this is, something to keep in mind as we're using the data. Other barriers for patients can be a lack of smartphone and an inability to afford data charges. Lastly, there can be a perception with lower quality care associated with telehealth visits. And so while it's clear that a lot of these barriers have been mitigated in the past year. This is just some important context to keep in mind, both as you are using the data and also building efforts to increase access to telehealth. That is all I had. Our report can be found on our website at this link here, and thank you so much for watching.
Okay. Hi, Katie. Thank you for your presentation. Keeping an eye on chat here. So let's see. We do have a question here. I'm going to actually take the second one that came in for the folks at NATO from David. But it says, are the patient barriers to telehealth more likely to impact Medicaid enrollees than those who are commercially enrolled?
I think there probably is a difference between the Medicaid population and the privately insured. I can't speak to any specific stats, off the top of my head, but I think that's definitely something to keep in mind, even though we are seeing that the Medicaid population is using a majority of telehealth in the state. I think the barriers probably are still affecting that population a little bit more than other folks. I will say this is a report that is definitely being used by a lot of state agencies, and we've seen a lot of collaboration both in sort of early 2020 and just continuing on to sort of build access and really address these and be very specific and targeted in those efforts for sure.
Excellent. And another question that's come in is, did you do any analysis with dually eligible patients, especially those that are in nursing homes?
That is a great question. We have not, teased that out specifically as its own report. Nursing home data is included in our broader report that is on our website, and you are able to drill down into those specific providers. But I definitely think that's something that we could focus on and really drill into more specifically in the future.
Okay, excellent. And sort of, I personally had a question that was sort of related. Other areas, as you think sort of to the future, that would be of interest to analyze, for example, vaccination status, or other medical conditions and impact on access to care, and then ultimately outcomes to care. Just kind of what are some other opportunities when you think about your data and what we know now, or what are the key questions now that might be future opportunity?
Yeah, I think we are really sort of starting to work on that in our future reports. What we've shown and what we've been working on so far is sort of just looking at telehealth. We see this very big, dramatic uptick, but we're starting to zoom out a bit more and look at, yes, we have this big increase, but what does that really say about care, like in general? Is that really sort of accounting for the lack of access to a lot of like in-person care? So that's definitely been sort of the next step that we are taking with that, and we're hoping to be even more collaborative with our state partners to sort of figure out what is the data that they need in order to address barriers both to telehealth and then just care in overall care for sure.
Okay. We do have a couple other questions that have come in. I think I'm going to go ahead just looking at these. I'm going to hold these again for the Q&A at the end. We'll do our third presentation, and I'll make note of these. So I want to thank you, Katie, and we'll see you at the end for some hopefully additional questions.
Thank you.
Okay. So our third presentation is from Ernie, Shippey, and Sam Hohmann with Vizient, and their presentation is Cancer Screening Trends During COVID-19 Pandemic and the Return to Normal Provider Patterns.
This NATO presentation is on cancer screenings and COVID-19. Both Sam Hohmann and myself, Ernie Shippey, were with the Center for Advanced Analytics and Informatics with Vizient. Here we're looking at cancer screenings for all different types of cancers throughout 2019 compared to 2020. First thing we notice is right around week 10, we see this big drop in cases. And it appears around week 26, starting to get back to normal here. However, when we looked at this data, we saw that there was at least 3 different clusters based on the time when the recovery happened. First cluster of hospitals we noticed are what we call the fast ramp facilities. There's 179 of those. We see this large drop, but we see the recovery quite quickly. So their delay wasn't very long. And then we start to see in 2020 much higher than normal compared to 2019 increases, where basically all but 3% of the screening backlog was filled during the last half of the year. And even going into 2021, we start to see even much higher screenings being done by these facilities. This is our majority cluster, 271 facilities in here. We see once again this big dip, and then we see a little bit slower recovery till this week, and then we started to see basically a matching up to 2019's volumes with no real big backlog recovery. Here we see 2021 quite a bit higher than 2019. The last cluster we notice are ones with the slowest recovery. 115 facilities, much longer decline period. And then we can also start to see they started to get back to normal. And then we see in 2021, once again, a large gap appearing. Now we're wanting to look at cancer screening types. So we started to look at 2021, the first 2 quarters of this year. And we noticed by the type, one of the biggest declines was in breast cancer screenings. Once again, it's the highest volume type of screen. And we could see that there was 299 hospitals that are still below threshold this year. We can see some, not as much, skin cancer. Only 15% of facilities are below threshold. We can see in the less prevalent types cancers, this is where a big pocket of the cancer screenings is really diminished. This pie chart showing us how comprehensive the screening recovery was for each individual hospital. So we see 10% of hospitals, all of the screenings are back to normal, and we see other ones are lagging. A lot of that's practice variation. But we have to remember in 2020, the top priority was to keep the continuity of care for the existing patients. You know, these have compromised immune systems, makes the process quite complex. So we saw quite a bit of collaboration between our hospitals and their local competition. So they started to have weekly, some of them still have bi-weekly meetings where they go out there and they're trying to make sure they can get the infusion, chemotherapy services, extra tests done for their populations when one might be hit with a surge and the other one has that extra bandwidth. On this graph, we have the dashed lines, which are what their comparison was to 2019. We can see for the normal cluster, pretty much higher than normal. We see the faster recovery starting to peak even higher. Area of concern is once again the low screening cancer centers are also the ones that are way behind on their chemotherapy sessions. We wanted to dive in a little bit deeper as to why there might be this not back to normal recovery for that one group. So we started to look at hospital stress based on COVID. So as you can see here, some hospitals were impacted very severely. We had 4% of our hospitals where they had over 26 weeks with a 15% or more inpatients being COVID-19 positive. Then you have on the other end, you had about 12% where they didn't have any weeks where it was that high. It was much lower. So we start to look at this And we even had one hospital that had 43 weeks with 15% or more. So we put together a stress score where we looked at where the 5 or 10%, 10 to 15%, 15 to 20%, 20 to 25, and then 5 points for if they're really slammed with 25% or more of their patients in there. So you can see quite quickly this first group here, their stress score 157 versus 10 for the other group. Here we asked the question, did hospitals that had much longer surges and much higher severe surges, did they correlate to a lower chemotherapy session volumes? Short answer is no. So we can see here, this is basically all the hospitals that had much higher than normal chemotherapy sessions in 2021. And we can see these are the ones that fell below. These are a little bit more normal. Now we can start to see the surge. So this is hospitals that were highly stressed that are in this area here. We can see just as many up here as we can see below. So we don't really see that correlation. In this study, we really wanted to look at these ones that were struggling with the chemotherapy sessions in 2021. So we looked at these 97 hospitals, we built some characteristics, and we modeled them and kind of came out with some patterns. We noticed that 47% of the hospitals, pretty high rate, were struggling with their chemotherapy volumes in 2021 that were right around that initial ground zero surge back in March of 2020. We also see hospitals that serve rural areas were also impacted as well. And this gets into the fact that some hospitals actually had 2 surges in their local community, and then when they're doing a lot of admission transfers from the rural areas. We also saw much lower volumes, 21% lower in this group compared to 2019 for the Medicaid and uninsured patients. Commercials were still higher. And we also saw a very large increase in inpatient cancer admissions. So we saw quite a bit more in these, 11% more inpatient cases compared to 2019. Meanwhile, the rest of the hospitals in this upper group had 3.4% less inpatient care. Okay, last slide. Here's our key takeaways. We still have that 20% of hospitals that are struggling both with screenings and the chemotherapy sessions. 80% of hospitals, very strong recovery. Most of them are starting to get their screenings back to normal, but it's happening in pockets between different types of cancer specialists. The big area that's a confounder that we're worried about is this perception of risk. So while that 20% are struggling, is it really the hospital system that's struggling, or is it that community at large that's struggling? There seems to be quite a bit of fear of COVID, COVID phobia. Now they've even done studies looking at COVID stress disorder. So it could just be their populations are really afraid to engage the healthcare systems. And then of course we saw the socioeconomic factors at play that are pretty much always at play in the healthcare market.
All right, excellent. Thank you. So looking at chat and while we're waiting for some questions to come in. So you mentioned about, again, fear of COVID. You mentioned in like that decrease in usage among those with Medicaid. And then previously we saw with telehealth, actually the reverse, an increase in use of telehealth with the Medicaid. Were telehealth services used with much consistency in the cancer treatment?
Well, we did see in the initial part of the pandemic, we did see a very large surge and then a continuing surge. But what we really saw was with hospital health systems that are accountable care organizations, ACOs. And that's a model that CMS uses to try to help prevent hospitalizations. Since a lot of those preventive care services use a lot of virtual systems, they have population health nurses, et cetera. In those systems, we saw continued high use within the cancer community.
Okay, excellent. Thank you. We do have a clarifying question that's come in. The decrease in chemotherapy is among those that were diagnosed with cancer or in general?
Just in general, we didn't get down to that specific.
Okay, thank you. And sort of, I think a follow-up or parallel question to that is, so are we observing fewer cancer diagnoses as well?
We actually are not, as far as 2021 is considered. We did see that initial decline during the surge throughout 2020, throughout the whole calendar year. But now in 2021, we're seeing a much more, I would say, 2019 trend.
And let's see, we're doing good on time. So were there any characteristics of the hospitals with slower return to recovery that you noted?
Yeah, the biggest ones we saw were mostly just that initial geolocation around New York City. We saw a lot more there. So we don't know if that's the trauma, the insecurity, just the overall death rates that were so high in that beginning of the surge that might be inflicting a little bit more fear in those communities. Some of the other facilities that didn't get that initial surge, they had more time to prepare and organize their care. So we saw a lot of continuation of care sessions going with our collaboratives. And so they were able to do more planning and probably able to message it quite a bit more. Whereas the other ones, there was no message except, stay home.
Okay. And let's see. How does late diagnosis factor into the current landscape? Is the next question that came in.
Yeah, that's an anecdotal one. I was speaking with a surgeon at Johns Hopkins about this a few weeks ago for a research project. And the one thing he was telling me, he's a head and neck surgeon. And he was saying, Ernie, he goes, this one type of surgery, he goes, I used to get 3 a year. He goes, I've already had 10 this year. So he's quite worried about some of the care. And plus we're seeing in 2021, the increase in inpatient hospitalization for cancer, which is quite dramatic in those facilities.
Okay, thank you. And I think the last question before we bring everybody back is for the reported decrease in breast cancer screenings. Was it tied to in-facility screenings, or were there any initiatives to go out in the community, do the screenings closer to where the patients live?
We did see that in, I would say, in New Mexico and then also in Washington State. We did see those two states. And part of that was, we just think just their, once again, they had a little bit more time. In Washington State, I know some of our hospitals were part of that initial COVID surge that we're dealing with the folks from the cruise ships. So they had really good documentation and trends, and we learned quite a bit from working with those hospitals, around even ventilation patterns, et cetera, for the patients. So we think that might be where some of those trends were happening.
Okay, excellent, thank you. So I believe we're going to go ahead and we're going to bring back Christine, Brian, and Katie to go ahead and join all the presenters together. And sure, this is going to open up to some other questions for folks, but I do want to make sure that we return, since we do have time, to some of the questions that came up during individual presentations. And Katie, you had several, and I'm just going to kind of maybe do one of them, and then the others kind of seem to sort of combine together. So, but did you look into whether telehealth was used more frequently for patients with specific mental health diagnoses?
That is an excellent follow-up question. We have not looked at that in our current report. The current one that we that is out on our website right now is sort of just like a super broad stroke of who, what, when, where, why. But I think, as we're sort of realizing what trends are about, like bubbling up to the top and require some deeper dives, that's definitely one of them that we hope to do in the very near future.
Okay, excellent, thank you. And I know there's a question that's up there on the screen. but I'm trying to connect these two together. Did the frequency of telehealth differ by the payer type? And also, again, was there a difference in terms of who was more likely to continue with care that you observed in your data?
Yeah, I think definitely sort of the consistent trend that we are seeing is that Medicaid patients seem to be using it more than other folks. There definitely are some interesting sort of age breakdowns. Adults seem to be using it, but we're seeing a large uptick in children. I think we haven't looked at specific like member trends and see like how many visits for a specific member. That's one of the several sort of long list or questions on our long list of follow-ups that we need to sort of start working on for sure.
Okay. And I think the last question for Katie from during her presentation part of the agenda is, were there any states that you've noticed or that you've heard of that were substantially different than what's been observed in Colorado and your trends?
As far as I know, Colorado has had a very similar experience to other states, but that's just been in my personal experience and the folks that I have talked to. I'm sure there are some other states that have had slightly different experience than ours, but I think it's been pretty consistent in what I've seen so far.
Okay, excellent. So there's a couple comments that have been coming in around screening, and again, some of the challenges in particular, as noted, down in Dade and Broward County, but being able to keep up. Here's the, yep, there's the comment right there. I do want to make sure also, there was one question at the beginning of our session for Christine and for Brian, where the participant was asking about your codes, again, for mental health and substance use disorder. They later found that there actually was a link. I want to just confirm that this is probably the best place to get that information, but then also ask a little bit of a follow-up question. There's so much decision making, within all of these codes because there's so many of them. Is that the best place where folks can kind of get an understanding as to what you included or excluded and or how you grouped the different codes together?
So I would say that there are two different places where we publish our codes. The link right there is absolutely the right one for what we are reporting on the dashboards. And again, our behavioral health codes are more or less exclusively based on the ARC, the Agency for Healthcare Research and Quality's clinical classification software refined as we're reporting on those dashboards. The much larger comorbidity measure that I mentioned for readmissions related analyses is also available on our website. We have a report on behavioral health and readmissions, and then the tech appendix to that. I don't know if I can post a link after the session or what, but the technical appendix to that does have our entire process for development of that list of codes, and it does contain the final list of codes as well.
Okay, excellent. Thank you. I think just to maybe extend that question out to the other presenters again, within the analyses, the criteria for including, excluding, how you define your measures, and again, these are oftentimes in new areas of exploration as a result of COVID. Just where can folks get additional information on how you arrived at those decisions and how you coded? Maybe Katie, you can start with you.
Sure, definitely. We base our definition mostly off of the Colorado governor's executive order for expanding telehealth in April of 2020. That was really the basis. We also looked at the guidance from CMS and other sort of national government health agencies. And then our full methodology and all of our codes is available on our website if anyone has any questions about specific things that are included or excluded.
All right, and Ernie and Sam, anything to point folks towards in terms of inclusion, exclusion methods, and so on?
Well, I think Sam will agree with me. We do a lot of member research requests, so we usually get about 100 publications that get published using our data set from our hospital researchers. So we typically have done quite a bit of this with different researchers. So a lot of times it's just picking up the phone or an email, and you'd be surprised how collaborative everyone is within our network.
Thank you. So we do have a comment with a question at the end that's also come into chat, that the switch to telehealth has been extremely beneficial for their health center, particularly in behavioral health. But there's now finding some pushback from payers on covering telehealth and wanting to then shift back to in-person. So the question is, have any of you all, are you experiencing similar pushback by payers? And I'll kind of maybe extend it further. Are you seeing within the data sort of a shift again in terms of where care is being received and telehealth versus in-person? I saw Ernie shaking his head, so maybe I'll at least from that start with Ernie. Sorry.
Yeah, I think we saw with the ACOs, because they're trying to do as much decentralized as they can. They have, diabetes coaches, prepping people for cancer treatment. So they're kind of ahead of the game because they've been building a lot of that infrastructure. So a lot of their payments, are working with the Medicare population. So they're incentivized to continue it. So in those, we're seeing actual increases. But once again, I do see a lot of payer pushback with the other hospital systems.
Chris, I would comment too. Robin Gilruth from Fair Health has worked with that kind of data with her folks extensively, and they report monthly on trends and changes. And of course, in 2020, as we moved into and through the pandemic, the increases in use of telehealth were in the 3 and 4 digits for various specialties. They currently report drop-offs, but their drop-offs are only in the order of 10% per month. So it's very clear that there's a different pattern of use. The one thing that I've seen, and I mean, this is just from playing with the data, is that mental health was historically used for, telehealth was used for a lot of mental health care, and that continues to be a significant portion, but it's not the proportion that it used to be, and it's not that there's less of it, it's just that there are other uses being used as well, and perhaps some of the others would have some comments about that.
That's a good point.
No, I would definitely agree that we are seeing that in our own data as well. We also, and just speaking to sort of differences in the patterns of care, I didn't touch on this in my presentation, but we were seeing a lot of differences in primary care use, and it looks a lot different before the pandemic, whereas now in the pandemic, or sorry, I guess now in 2020, you're seeing a lot more office visits being administered through telehealth, whereas before that was like a very small slice. So I do think we're seeing it sort of play out in the data of sort of figuring out which services do make a lot of sense to continue to give over telehealth and which don't make sense for a variety of different reasons.
Let me add one more thing just to put it in the mix, and I presume the rest of you experienced that too, is that the definition of telehealth, I think it's broadened a lot, but not everybody uses the same definition. Mm-hmm. And that's nobody's fault. That's not that they're wrong. It's just that it is different. CMS reimburses for certain kinds of things. Private insurance reimburses for certain kinds of things. There's some restrictions, some exclusions, and I think that complicates what we mean by use of telehealth and looking at those changes over time. That shouldn't keep us from looking at it, I don't think. But that is kind of a complicating factor, I think, in my mind.
Very good point. And again, I want to jump in here. Unfortunately, we are out of time, although we can probably keep the conversation going. I do want to thank all of our participants today for the questions that you submitted in chat and your engagement with our presenters. I want to thank our presenters for your presentations today and your time answering the questions. And also want to thank our sponsor, Maximus, again, for the session today. So with that, Norm, I will just hand it over to you.
Thank you, everyone. We will see you all at our opening day keynote and our awards session. You don't want to miss so that's going to be special opportunities to recognize some influential people in health data and just basically say thank you to them. So I hope you'll show up right now at 4:30 Eastern in about 10 minutes at the opening keynote and the awards session. Bye, everyone.
Thank you.